Welcome to the third Perfusion Summit here in Paris. I'm so delighted to see so many people in the audience, and to those just coming in now, there are plenty of seats up in front. You see well from up here, and it's kind people sitting here, so feel free to get to the front of the room. I just have some practical announcements for the people who are arriving now, and that is that luggage and coats, you can leave those in the Fontenay area, so out here in front where there will be people looking after it, and you can put it next to the posters. Also, the check-in at the hotels is guaranteed from 4 o'clock, but you may try to inquire in the reception whether you can get your room earlier in that. And then if some of you are interested in the cone beam CT presentation tomorrow at 8:30 a.m., there's still a few places, so please register at the counter if you're in the registration table if you're interested. And I should say that all the preparations for getting CPD points for participating in the summit has been finalized, and so we expect that you will all be able to receive points for that. Then I want to proceed and give just a few sort of remarks about what it is that you're going to be seeing today. Some of you have been here before, but just to reiterate. So what we are trying to say is, or examine with these techniques you'll hear about today, is how much oxygen do cells actually have available to them. And we used to think that we could determine that by looking at blood flow alone, and from dynamic images of contrast passages, here it's MRI, but it could also be CT. And then we used to make maps of cerebral blood volume and mean transit time. And this is what we call classical perfusion MRI, or classical perfusion. What we overlooked when we made that assumption about oxygen availability is that the distribution of blood at a microscopic level also matters. So I've illustrated that here with two capillary beds with two different distribution of capillary transit times. And you can see because capillaries with fast blood transits, there's very little time for tissue to actually access oxygen from the blood. And therefore the oxygen extraction is poorer when capillary flows are disordered than when they are homogeneous. So therefore, we need to supplement the mean transit time with the distribution of transit time. So the broader that is, the more it affects how oxygen is actually extracted from the blood. So this measurement, CTH, is one that you'll hear many times today, or several times probably. So this has profound impact on how we think of diseases in the brain. So what we overlooked is that, of course, CBF determines how much blood comes in and becomes available, but CTH determines to which extent cells can actually access it. So that is, of course, critical. And in terms of disease, we were always thought that when cells die because of a lack of oxygen, it's because there's low blood flow, what we call ischemia. But this means that there's another reason, potential reason, namely that there are disordered capillary flows. And it also means that diseases where there's normal blood flow can in fact suffer hypoxia, and you're going to see examples of that today. So this is just one example about stroke, the first topic today. If you have occlusions or constrictions of capillaries, that poor distribution of blood will give hypoxia in some regions because there's low capillary flows, and shunting in others where blood passes through capillaries too fast to have its oxygen properly extracted. And for that, Kim Moritzen developed a technique that allows us to use the same raw data as you saw in the beginning, but determine transit time heterogeneity. So the leftmost images here, this is just an example of how that looks in internal carotid artery occlusion and stenting. And so the modern perfusion software, what you're going to hear about today, provides those classical parameters you know already. Then they also provide CT8, and one parameter we'll hear about, RTH, so the ratio between that standard deviation and the mean, because that is, to a great extent preserved across brain tissue. So any deviations from that seems to be pathological in many cases. And then it also, with that work you saw in the beginning, it calculates based on those two parameters how much oxygen can biophysically be extracted with these perfusion parameters. So that means that it makes maps of oxygen extraction fraction and CMR2. So there are no measurements of oxygen involved, of course, but it tells biophysically what would they be if there's equilibrium between the bloodstream and what you see here. So today we're going to be looking at the forefront of understanding how our capillaries are involved in stroke, neurodegenerative diseases, and cancer. And I can say, having looked at the program, that I already look very, very much forward to it.